My mother-in-law passed away the week of Thanksgiving. She had lived with us for 9 years. She moved in with us after she was discharged from a hospital in West Texas on hospice with end-stage heart failure. She came up here to Utah with us. Our hospital system is very difficult in terms of capacity, and sometimes access is a problem. And so one of my drivers is that my mother-in-law was able to access the wonderful care here because of the wonderful care at University of Utah Health. We were able to get 9 years.
That was Juan Hernandez, one of the founding members of the Heal at Home program at the University of Utah Health. His story reflects the deeply personal impact that healthcare, especially home-based care, can have on families. Most of us will spend the majority of our time at home, in living rooms and kitchens, in the comfort of our routines. And sometimes, life breaks that rhythm, and you find yourself seeking care. The kind that usually means sirens, sterile walls, fluorescent lights. As an emergency physician, I'm trained for that unexpected, urgent, and unraveling uncertainty. I encounter people from all walks of life, and with my team, try to keep them alive in a system that's often overcrowded, rushed, and under immense pressure. But here's a question we've been grappling with. Why are hospitals the only option when the same standard of care, or even better, can be provided at home? That's where today's story begins. Welcome to In the Heart of Care. I'm Dr. Panchal at The Ohio State University. We're diving into hospital at home programs, a growing movement bringing high-level, hospital-grade care into patients' homes. Now, where could a hospital at home program work best? It turns out where the need is greatest. In big cities, where aging populations are growing, hospitals are crowded, and getting to care isn't always easy. Places like New York, Los Angeles, Chicago, Boston, where some healthcare systems are already rethinking the model, asking, what if the hospital came to you? Not just shallow check-ins, but full-scale, hospital-level care at home.
So my first job is I get to take care of patients. I do primary care and home-based primary care at a community health center in Jamaica Plain in Boston, where I see mostly patients who have Medicaid for their insurance.
That's Dr. David Levine. He's the clinical director of research and development for Mass General Brigham Healthcare at Home.
And I also get to take care of patients in the hospital, which is kind of old-fashioned.
It's unusual for one clinician to do both, but that dual perspective, clinic and home, gives Dr. Levine a unique lens.
I have the privilege of delivering acute care at Brigham and Women's Hospital and Faulkner Hospital and all of the Mass General Brigham hospitals, where I principally do home hospital care. So that's a really big part of my job, is getting to take care of patients. And then I also get to do a lot of research. I'm a health services researcher, and I get to do a lot of fun work basically focusing on care at home and bringing a really advanced care to patients who typically would have had to have come to a facility to get their care, and instead we bring it to them.
You see, Dr. Levine is not just practicing the model, he's helping define it, tweaking what he learns into literature so others can follow suit. He led the country's first randomized controlled trial of home hospital care.
We were able to do the country's first randomized controlled trial when I was a fellow about a decade ago, and then that was so successful, we followed that up with a larger randomized controlled trial, also at Brigham Women's Hospital and Brigham Women's Faulkner Hospital. We were able to show that patients have lower 30-day readmission rates after they're done with their home hospital versus their traditional brick-and-mortar hospitalization. We were able to show that patients moved a lot more as well when they were at home.
And the results? Fewer complications, faster recovery, better outcomes than traditional hospital stays.
All the things that we typically would have done in the hospital, like IV antibiotics, IV fluids, different sorts of advanced imaging, continuous blood work checks, all those kinds of things we were able to portabilize, miniaturize, and essentially bring to the home, where we were able to show that when you take patients home who need to be in the hospital versus keeping patients in the hospital, it's actually had better clinical outcomes.
You may be wondering, how did Dr. Levine go from caring for patients in the hospital to bringing hospital-level care into their homes? The story actually begins much earlier.
I Used to be a high school teacher, actually, in Chicago Public Schools. I worked on the west side in Garfield Park, which is a very tough part of town. And my students actually would get shot walking out of school. They would be pregnant before they wanted to be pregnant, and they would end up homebound as well, temporarily homebound.
And so Dr. Levine would visit his students, making sure they didn't fall behind.
I had an amazing opportunity to do home visits for them as a chemistry teacher. I would go to their home, make sure that they stayed up to date in my class, because you had to pass chemistry if you wanted to graduate from high school. And so I was able to do my first professional home visits as a high school teacher. And that was an amazing experience for me, because it really showed you that when you are welcomed into someone's home, you have an amazing opportunity and responsibility to really help in a big way that you may not have been able to previously. And you really get a lot of the things that they're going through when you step into their home that you would never be able to understand if you were in your classroom or in your clinic.
It was a lesson that stuck. Understanding the complexities of a person's life beyond the classroom, really meeting people where they're at.
So I took a lot of those lessons with me for a long time, ended up in medical school, did a lot of community-based and home-based work as a result of my experiences, and continued that throughout my training.
The reality is, hospitals are filled with risks. As healthcare workers, we're trained to treat strangers, and often we get a snapshot of their lives. We work with ambiguity, building a case based on limited information. But what if we could care for patients in a way that goes beyond the clinical?
About a quarter of patients have some sort of an adverse event when they walk into a hospital. And about a quarter of those adverse events are preventable. And that is extraordinary to me, because you would never walk onto an airplane if 1 out of 4 times something went wrong. We have always attempted to either provide the same level or better level of care at home than in the brick and mortar hospital.
And that's the challenge. Could we replicate or even improve upon the care typically provided in a hospital, but in a patient's home? Could technology, community health, and advanced medical practices combine to give people the care they need without the risks of the hospital environment? And the answer, so far, seems to be yes.
We needed to bring new technologies to the model that didn't necessarily exist. We design systems in home hospital to be passive on purpose. We don't want people to have to be entering their vital signs or taking measurements or things like that. We want things to basically just be working in the background. And that's essentially how we've designed the vast majority of the equipment that we bring in.
As Dr. Levine's program grew, it became clear that the future of hospital-at-home care wasn't just about scaling back the hospital. It was about reimagining what healthcare delivery could look like.
I had been practicing home-based care for a while in training. As a resident, I was actually in Bellevue Hospital in New York City and NYU, and saw just an enormous need for home-based care. Patients couldn't get to us. They couldn't get out of their homes. They're homebound. And it turns out almost 15% of the population over the age of 65 is homebound. And if we look at historically marginalized populations, oftentimes 35% of some of those populations are homebound. So it's an enormous percentage of folks who can't get out of their home. We needed to bring continuous monitoring to the model so that we could have telemetry for a patient continuously when they were at home, so that we could detect when they fell when they were at home. We needed to bring point-of-care laboratory systems to the home so that I could snap my fingers and get a patient's basic metabolic panel and H&H. And so really needed to upskill the folks in the home so that they had more capabilities. And so that was a big part of our build, was not only learning and leaning on kind of the prior work, but also infusing it with a technology-based approach. Our hope is that we can just continue that momentum. It has really blossomed. There are now over 380 hospitals around the country with waivers in 39 states today. And my vision is really to see that continue to grow. I want to add a 0 after that 380 hospitals, essentially, because we want home hospital to be the default option. We want folks to come to the hospital and the first thing that they're offered is care at home instead of care in the brick and mortar.
While Mass General Brigham is one of the pioneering programs in Boston, other healthcare innovators are taking similar steps to bring care to patients where they live. One of those trailblazers is Juan Hernandez, nurse director of the Heal at Home program at the University of Utah. Like Dr. Levine, Juan has been a key founder of such a program, focused on bringing advanced, compassionate care directly to patients in their homes. Hi, Juan. Thank you so much for joining me on In the Heart of Care.
Thank you so much, Ash, for having me. Glad to be here with you.
Tell me a little bit about your work. What do you do? How does that make you feel?
I honestly think I have one of the best jobs at University of Utah Health. I am currently leading the Heal at Home team.
Juan, I'm excited that you think it's one of the best jobs. So with that in mind, with this work, what brings you joy?
I think it's this. When we first started and we're kind of conceptually putting this program together, we had one tenet in mind, and it was that whatever program we came up with, the patients had to be just as happy or happier with the care and outcomes that we were going to provide. And we are so, so happy to say that we have achieved that. We asked the patients if they would refer a friend or family member to this program, and 95% of the patients say that they would.
One of the things that really strikes me is people's personal journeys. What started you along your nursing career?
I've always loved medicine. I've always been excited for the science behind medicine and trying to improve the health of humanity, of our community, right? And as a nurse, one of my very first jobs, I worked in the cardiology floor. And a lot of the times I would get my patients ready for discharge. And I'd be like, gosh, if I could just follow my patient home and make sure that their growing site wouldn't bleed and make sure that they would start taking their medications correctly, we would be able to kind of tuck them into bed at home. And I thought that would be an amazing way to kind of end off their acute care stay at the hospital. Of course, that's not practical. But now with this Heal at Home program that we have at University of Utah Health, we're kind of doing the next best thing. We're partnering with our trusted home health agency, Community Nursing Service, and doing just that. We have developed post-surgical protocols for our nurses and therapists to do just that. And many times, within just a couple of hours, they are actually at the patient's home doing what we just were talking about.
Well, it sounds like some of those past experiences you've had have really changed you and impacted you in a powerful way. So how have you translated those experiences into what you're doing at other people's home now?
I think that translates beautifully into what we're doing, just because having that knowledge base. And again, when I say I have the best job, I kind of straddle both worlds. I straddle the acute care side. And with my role as director of post-acute care, I oftentimes am talking a lot with skilled nursing facilities and home health agency providers to make sure that we are seamlessly transitioning patients to the next level of care. As you know, Ash, anytime there's a transition, even intra-hospital, that puts the patient at risk for complications. And so that's really what we're working on is how can we more seamlessly and safely do this transition?
I love that you said that. It's making me reflect because as a physician myself, I'm always hoping that my patients are going to get great follow-up, that I put my discharge plan together and that we are all connected and we're holding hands and singing Kumbaya and going in the right direction. But I'm an ER doc and I see the bounce back, right? I see the patient who's fallen through those gaps. How do you see this program filling that gap and making sure that we close that loop?
Yeah, and that's all it is. It's kind of like that old saying goes, right? 75% of the world's problems could be solved by improved communication. And that's really, and that's really what we're doing. We have this saying about our secret sauce. One of the things in our secret sauce for success is that we have protocolized all of the care for these post-surgical patients. So what we've done is we've actually had you as the emergency doctor at the table there when we are putting together our protocols protocols so that you know what kind of care the patient is going to get day by day once they're discharged from the hospital. So for the first time, we have the home health provider at the table with the surgeon and or discharging physician at the table. So we can ask, discharging physician, what are your big three concerns about discharging this patient home to home health? And we can mitigate that because the home health providers, they're listening to those things. And then what we do is we come up together with a protocol of care so that that provider knows that their patients are going to get A, B, and C provided in their home in a timely manner per the protocol that he or she develops.
It sounds like there are some great takeaways of clear, actionable items that you just kind of described. But what were some of the initial challenges you encountered getting this off the ground?
Yeah, there were several. Number one was actually getting buy-in from our organization. The way that our group got started was we actually were tasked with operationalizing a hospital at home program. When we put all of that together and presented to our organization, they actually decided not to operationalize a hospital at home program just because of the limitations of the diagnoses that we could treat. And also there was a pretty heavy lift with IT support that was going to be necessary. But then what we said is like, hey, if we can't do this, we have another idea for transitions of care program where we could care for people in their home and there won't be any out-of-pocket cost to the organization initially.
Wow, it sounds like a big part of it is that aspect of what the organization can do. But can you tell me a little bit about how you guys determined the best candidates for the Heal at Home program?
Excellent question. Yes. What we initially did was we started to talk to potential internal customers. We started with our orthopedic, our joint program, because they had already been working with the CMS guidelines in terms of having transitions of care, and they already had a lot of experience with this. And so that's where we started. We said, hey, we have this idea of how we can streamline your discharges even more. How would you like to have a nurse and or therapist in your patient's home within, instead of next day, 2 to 3 hours, depending on the time of discharge of your patients, and they can start therapy and or nursing care that quickly. And of course, the orthopedic surgeons were on board and excited, and that's where we started. And our ortho, hip, and knee program is the one that actually is kind of our flagship program and have the most admissions to our Heal at Home program year over year from that initial program. I'm happy to say also that since then, now we have a very heterogeneous list of internal customers. We now have 22 operational programs as of today that go from anywhere from orthopedics, maternity. We have an emergency room program that is actually, the way that this program has evolved is an admission avoidance program. And we even have super specialized programs like liver transplant and our transgender program as well.
So it sounds like at this point, you've matured enough that you've designed it to a broader target population.
Most definitely. And that's what's been so excited. We started with post-surgical patients. And again, we started with orthopedics. And now, little by little, we have been able to get to more specialized programs. We have a program that is now a complete admission avoidance program in our emergency room. And now we have this on-demand program with our ortho trauma providers, where we actually take the patients with little or no notice, because of course you can't plan a trauma, right? So if a trauma patient comes in and wants to discharge, we can actually care for them in their home with this program as well, which was a huge step for us, because before, one of the things that we banked on, one of the items that was in our secret sauce, was that the home health provider could actually build a schedule, because all of these were post-surgical programs. Well, now we were able to pivot and successfully take more of an on-demand clientele and have been just as successful doing that.
You're listening to In the Heart of Care, a podcast about leadership in healthcare, where we explore what it really takes to build strong teams, foster resilience, and stay ready in the moments that matter most. We're brought to you by RQI Partners, a partnership between the American Heart Association and Laerdal Medical. So, I want to pause because I think this is amazing stuff, but I want to reflect back. I'm going to take you back in time all the way to the pandemic because I know that's part of your origin story. And I want you to think about and just tell me a little bit about how all this came about for you when you have all this going on with the pandemic and now you're trying to do something like this.
Yeah, I mean, if all of us can recall, right, the pandemic was this thing that came from left field. It completely changed hospital healthcare operations. Well, it changed our society as a whole, right? And one of the things that our organization was trying to do, like I said, is a hospital at home program, a viable option for us to continue taking care of our patients. Because we are a level 1 trauma, we're an academic medical center, we actually take care of patients representing about 10% of the continental United States in the Intermountain West. We were trying to figure out how could we squeeze out efficiently out of our available hospital beds. And so when the organization decided that hospital at home would not be a viable option for this, then we quickly pivoted and said, hey, our team is actually thinking of something that we can actually apply to a much bigger patient population.
Sure.
And we could do it at no cost. That's when they're like, all right, show us what you could do. And those were our tenets. Number one was that the patients had to be just as satisfied or more satisfied with the care they were going to receive. Number two, that it was not going to cost the organization anything until we could prove the concept. And number three, that we would very, very closely track how many bed days we could save the organization by improving the transitions of care.
Well, you know what? We've talked a lot about the structural pieces. I'm going to take us in a totally different pathway, okay? I'm interested in understanding the change of space, right? So when we think about nursing in general, we think about a hospital system. We think about what you used to do in the cardiac unit, in the ICU, and all those kind of different things. Now we've changed the location. We're bringing them into people's homes. How did this change the role and the whole gambit of what a nurse has to do?
What we've done is we've actually just empowered those home health nurses and home health physical and occupational therapists to work at the top of their license. Instead of the home health and hospice nurse and therapist receiving an order that reads skilled nurse and PT to eval and treat for heart failure, we are giving them a very, very detailed care protocol based on the patient's diagnosis and or surgery. Now what we're doing is we're empowering that nurse and or therapist with protocolized care so they can manage that. So the only time the provider is going to receive a call is when the nurse and therapist really do need that higher level, that prescriber level of care when there's a complication in the home.
Yeah, I mean, it sounds like they're getting a lot of the high level of care that we do provide in the hospital setting, but it sounds like also that they're receiving something they don't normally get in the unhospital setting.
I see it as they are receiving an extension of their surgeon and or provider following them into the home because that surgeon and provider wrote the care protocol that the nurse and therapists are going to follow. And that has been a huge difference maker. And one of the symptoms of that is that we have been able to, again, add on more internal customers in this last calendar year. And what that has done is that has netted our healthcare system 556 saved bed days in calendar year 2024.
Juan, one of the things that really struck me as you're talking is that this core model, which features nurses in a new role, almost suggests that there's going to be gaps in knowledge going into people's home, but that doesn't really seem to be the case.
For the most part, you are correct. The skill base, the skill set of a home health nurse and or therapist is solid, and there has been very minimal necessity for us to train the nurses. The only times that we've had to do that where they need specialized training is for the very, very specialized surgical programs. I'll give you one example. In our transgender program, we are currently taking care of patients that have had a vaginoplasty. And there are very, very specific steps to taking care of a neo-urethra and a neo-vagina that had to be taught in the outpatient clinic in our campus. So what we did is we identified that as a needed learning achievement for the nurses that were going to take care of this specific patient population. And so then we scheduled training specifically for them, for every nurse that was going to see these patients. That mitigated the education gap. And we have been very, very successful at taking care of these patients in the home. And we have been able to reduce the average length of stay for these post-surgical patients by 2 days. And if you can imagine that type of very sensitive surgery, what better place than home, right? You want to go home. You want to be at home with this very sensitive surgery. And we have been able to shave off 2 days in the hospital, and the patient is able to have all of the care provided in the comfort of their home by nurses that have the same training as the outpatient nurses in our clinics now.
You know, one of the things that you mentioned was the secret sauce. I love that concept because so much of the things that we've learned in medicine lately has been, hey, we know how to do this, but the challenge is true implementation, making it happen. And I love hearing how you've made it happen. So I guess my next question has to be, what's the next big challenge? What's the next big opportunity? What are you preparing for?
Yeah. So what's going to be Heal at Home 2.0? So we have been extremely focused on inpatient bed capacity. That was our challenge set to us. And as you have heard by some of the outcome measures that I have reported to you, we have been very successful of that. I really do think that the next step is going to be, how could we increase capacity and efficiency in our outpatient clinics? For example, is there a patient population that is being managed outpatient-wise that we could collaborate with our trusted home health partner, community nursing service, to reduce the number of outpatient visits in a specialty clinic by leveraging the home visit and using that home visit in lieu of an outpatient clinic? One of the specialties that come to mind is a wound clinic, for example. If there's a patient that has a significant wound that is being seen 3 to 5 times a week in an outpatient wound clinic setting, can we leverage this partnership and have a couple of those visits be done at home by a home health nurse that is well within the purview of the home care setting? We have been doing excellent wound care in the home for decades now. And what happens is, again, it's a win-win because the patient, it's less traveling they have to do. And then that opens up several visits in the outpatient clinic that typically has a long wait time for new patients to be seen in.
I guess more than anything else, you've kind of sold me that I should be thinking about doing something like this. I mean, and that's great. It's the energy, the power that you bring to the question. I guess the next thing is, what's the advice you would give someone who's considering taking this to the next level, thinking about adopting a program like this for their system?
Number one, I think you need to start slow. Be very strategic as to who you choose is going to be your first and second internal customer. Start off with low-hanging fruit. Don't try and take on really, really acute patients at the very beginning. Be very strategic about the patient population that you choose to start this off. Number two, from an operations perspective, most organizations have long lead times for any type of customized IT support. We have had to circumvent builds in our electronic medical record because there's a long lead time for that. And so be ready for that. Be ready for having to be creative on how to communicate, how to create order sets. If your IT department is backed up for months on end before they could get to your trouble ticket, be prepared for that as well. Those are the 2 things that I would recommend to anybody. The third one is try it, do it, reach out to us. We'd be happy to share our experience with anybody. But again, with the outcomes that we have done in our extremely busy academic medical center, the reason that we were kind of given the level of support that we were given is because we were able to show, again, a significant reduction in length of stay. We were able to create these bed days that are just going to improve access to our community for care at University of Utah Health.
So Juan, it sounds like, I'm just going to put some thoughts out there. It sounds like number one, taking care, putting empathy into the work we do, bringing that care to someone's home, getting them out of the high-risk environments of hospitals, and putting them back to where they can be nurtured and supported with the infrastructure that you've developed is the next phase of what we can do. Juan, thank you so much for coming in today and having a chat with us.
Thank you so much.
When we bring the hospital to a patient's home, we're not just treating their condition, we're empowering them to heal on their own terms, in the comfort of their own space, surrounded by the support they need. Thank you for joining me on In the Heart of Care. In the Heart of Care is brought to you by RQI Partners. Our producer is Ebian Abdigir. Our sound engineer is Luke Badio. Our project lead is Miria Saint-Aubin. Additional production support is provided by Jar Audio. I'm Dr. Ash Panchal. Take care of yourselves, and until next time, stay well.